Good morning, everyone. We are going to talk about time tracking and its role in collaborative care. As Sujina just said, I'm Diane Powers. I'm the co-director of the AIM Center here at the University of Washington, and I'm joined today by Monica Harrison, who is a clinical trainer and practice coach. So by the end of this session, you should be able to understand the key principles of collaborative care, understand the collaborative care team as it relates to time tracking, describe the time tracking requirements for billing the collaborative care codes, and the uses of time tracking other than billing. So according to a national study conducted by SAMHSA, only 47% of US adults with a mental health condition received treatment in 2021. Of those who do receive treatment, most receive care in primary care. A large national study found that over a 15-year period, the proportion of all mental health visits that occurred in primary care rose from 54% to 60%. Primary care is where the majority of people receive mental health treatment for diverse mental health conditions. Approximately 30 million patients have a prescription for a psychiatric medication in primary care, but only approximately 25% have been shown to improve. And primary care providers struggle with having support, with over 2/3 of PCPs complaining about poor access to mental health care for their patients. If we recognize there's a gap between the number of people who need mental health services and the amount of mental health care that's being delivered, let us consider how we can close that gap. And for those of you who are here today, I'm sure you know that collaborative care is one of the ways that we can do that. These are the few of the typical solutions that people have considered to try to close this gap. Let's see here. So the proportion of psychotropic medications prescribed by primary care providers increased from 67 to 77% over a 15-year period. And these are not just antidepressants. That's a common misconception about integrated care and collaborative care. Nearly all of the collaborative care trials included patients with moderately severe and in some cases even severe symptoms. And many studies, especially those conducted in the past 10 to 15 years, have examined collaborative care for a wide range of mental health conditions, not just depression and anxiety. The reality of the current mental health system is that most patients, regardless of symptom burden, simply can't access specialty care or can't do so in a timely manner, making primary care the de facto mental health treatment system for the majority of patients. The prevalence of depression in primary care has also increased over time. So whereas it used to be in the 8 to 10% range, it's now in the 10 to 15% range, and even higher than this among certain populations and settings. So as we all know, COVID fueled a dramatic increase in mental health conditions worldwide. Across multiple studies, the prevalence of depression and anxiety shot up in 2020 and hasn't eased with the return to more normal operations. Collaborative care is a systematic approach to integrated care that's based on the chronic care model and has the strongest research evidence to date. This slide shows some of the key features of collaborative care. Collaborative care starts with a primary care practice that has an integrated behavioral health provider and an active informed patient. You can see that in the upper left corner. The primary care-based team is supported by regular use of outcome measures such as the PHQ-9 depression scale or the GAD-7, which is used every time a patient presents for care to see if patients are improving. A depression registry helps clinicians track which of their patients are improving and who need changes in treatment if they're not improving. The use of evidence-based psychotherapies that are brief, structured, and appropriate for primary care is also a feature. And regular reviews of all patients who are not improving with a psychiatric consultant. The 5 key principles of collaborative care really serve as a foundation for any conversation about collaborative care. Collaborative care starts with a patient-centered team comprised of the patient, a primary care provider, a behavioral health care manager, and a psychiatric consultant. They work together using these other principles to provide care to patients with diagnosable mental health conditions in the primary care setting. Collaborative care is population-based. So care is provided to an entire defined population of patients in a medical setting. This is one of the ways in which a registry is key. It helps keep track of that entire population and to organize and drive the care that's delivered. At the heart of collaborative care is measurement-based treatment to target. Mental health symptoms are measured at baseline and repeatedly throughout treatment to measure progress toward clinical goals of symptom response and remission. This is also where a registry is a key component of collaborative care. Treatments that are used should be evidence-based and appropriate for the primary care setting, meaning they are brief, structured, and focused on symptom reduction. And finally, collaborative care is accountable to patients, other members of the care team, and payers. The first principle, patient-centered team, represents the concept that a team of providers works together to provide patient-centered care. Collaborative care begins with the patient. In this model, patients are cared for by a team, which includes a primary care provider and a behavioral health care manager who are located in the primary care setting, and a psychiatric consultant who's typically located off-site. The psychiatric consultant provides guidance and support to the team through systematic scheduled consultations, typically weekly, with the care manager as the primary contact. The team works together to provide care guided by patient preferences with the goal of empowering the patient to shape their own care. The bold lines on this graphic represent direct ongoing communication, and the dotted lines are more indirect communication, depending on how you've set up your collaborative care model and the psychiatric consultant's recommendations. The second principle is population-based care. This means that rather than focusing just on those patients who present themselves for mental health treatment, you identify a population of patients that need help. So to do this, you utilize a comprehensive list of all the patients who are currently actively involved in treatment. So shown here is an example list of currently enrolled patients that represent a defined population who get targeted, proactive treatment. This comprehensive list is called a registry. This particular registry is the AIMS Caseload Tracker, but there are other registries that you can use as well. Many people may be familiar with the idea of a registry from programs in diabetes care or other chronic illness care in which a registry is typically used. This sample registry lists current behavioral health measure scores and recent visits, and allows you to quickly look to see which patients are in need of a follow-up contact and who should be discussed with the psychiatric consultant during the weekly systematic caseload review meeting. The column at the right shows the total number of minutes spent with each patient during the calendar month, which is something we're going to focus on today. The next principle is engaging in measurement-based treatment to target. This is the idea that at the beginning of treatment, a patient-centered goal is identified, and treatment is systematically adjusted until the target is achieved. So for example, this graph shows the plot of the PHQ-9 scores over time. Many clinics pick a PHQ-9 score of less than 10 as a treatment target. So the PHQ-9 score is located on the y-axis and time is located on the x-axis. And the blue line represents a patient who came into treatment and then steadily got better. The red line represents the GAD-7. The team can use this information to make sure that adjustments to treatment are timely and help make sure that you are driving toward the goal that you have for treatment. Collaborative care is an evidence-based approach that works for patients that take medications only, use psychotherapy only, or both. Therapy or counseling is not a prerequisite to enroll a patient in collaborative care. I'd say that's one of the #1 misconceptions about collaborative care. You do not necessarily need to be providing psychotherapy to a patient for them to benefit from all the other components of collaborative care. Treatment plans should be individualized for each patient and based on patient history, preference, symptoms at baseline, which modalities are most likely to address those effectively. Treatments should target the biopsychosocial model of mental health disorders. This means supporting the whole person treatment, including developing the comfort of all team members to make a wide range of recommendations, from evidence-based psychotherapeutic interventions as well as medication recommendations. The last principle is accountable. The collaborative care approach very much concerns itself with being persistent in achieving improved clinical outcomes and improved quality of life for the patient. In order to achieve those improved outcomes and ultimately improved quality of life for patients, it's critical that the other principles of collaborative care are firmly in place. That is how you can look to achieve accountable care for your patients. In terms of access, we mean being able to reach more patients to provide care and then decreasing the wait time for care once these patients have been identified. In terms of accountability, we mean having a systematic approach to screening patients in need and then taking ownership of the caseload of patients to track their treatment progress and ensure they get better. To do this well requires a commitment to the population of patients that you serve and a commitment to a mindset of continuous quality improvement. That is a commitment to reflecting on the way that the team delivers care and systematically looks for ways to improve. This principle of accountable care becomes the compass the team uses as a guide when decisions need to be made about working with the patient and monitoring your program outcomes. And now I'm going to
So
turn it over
let's,
to Monica.
all right, thanks, Diane. So let's start at the basics of what we mean when we say time tracking. You've heard us say it a couple of times now. So time tracking is counting the minutes every time a collaborative care service is provided or delivered. And we'll provide some examples of the actual delivery of services on the next slide. But time tracking is usually just thought of for billing. Since you do need to know the amount of minutes that corresponds with the appropriate billing CPT code, but it can also be used for overall program monitoring and caseload monitoring as well, which we'll talk some about today. So here are some examples of what services can be counted as you're tracking time. So any clinical activities of the behavioral health care manager can be counted. So here are some of those. So warm connections, or sometimes called warm handoffs, any clinical contact with the patient, communication with other treatment team members, communication with outside providers or individuals outside the clinic. So sometimes you might have a patient who's receiving traditional psychotherapy outside of your practice. Charting, but we have the words minimal there because we recognize that how much time it takes for individuals to chart can vary. So it is not the thought process that you are spending 15, 20, as a previous traditional psychotherapist myself, sometimes 30 minutes charting on a patient. So it's not the thought that that's that a much amount of time being spent charting, especially if you're doing some concurrent documentation, which means you're charting or documenting at the same time of the activities you're providing. So you'll have to have some conversations within your practice about how much time you're providing for charting. Also, there's registry management and then the weekly systematic caseload review time. So it is important to note here that some systems have a shared behavioral health care manager role that splits up these activities. And in those instances where the individuals providing that share role meet the criteria for a behavioral health care manager, which I'll also discuss, the minutes from all of those activities being shared can be counted. When trying to decide if an activity can be counted or not, you should determine if the activity meets the criteria, some of the criteria that we have listed here as minutes not to be counted. So administrative activities like just scheduling appointments or doing appointment reminders, or the monthly billing that some individuals do at the end of the month, those are considered administrative activities that should not be counted. Any of the time of the primary care provider themselves or the psychiatric consultant themselves, those minutes should not be counted. We'll talk some when we get to the billing about why, but time for those providers or psychiatric consultant should not be counted. So here's an example of tracked minutes using the AIMS caseload tracker. There's a spot to enter the minutes for each activity that or service delivery you provide. And you can see for the month in this example on the far right, the minutes spent providing collaborative care to specific patients. So utilizing this monthly view as a behavioral health care manager helps with a few caseload monitoring things. You could see who has not received any collaborative care services for the month because the minutes there would equal 0. You could see who spent a lot of time, who you spent a lot of time on for the month providing collaborative care services, which could highlight a whole host of things, including patient acuity. So maybe that's a more complex patient, so you've had to spend more time on them, and then maybe they need to be discussed during your systematic caseload review time. Or you could see who you've not spent much time on that month, which could mean maybe you've not spent a lot of time because they need a relapse prevention plan, they're almost done, they're doing well, or it could just be, close to time to ending their episode of care. You can also quickly see if someone hasn't met the minute threshold to bill for collaborative care services for the month, and if it is an applicable service that you could provide to them for that month for billing, you could do so and get those months counted. Here's an example, still using the Ames caseload tracker again, but a more kind of longitudinal view of minutes. So this view assists with more program monitoring. So from this view, you could see the amount of time spent on providing collaborative care to patients in general. You could see, are there some providers who are referring maybe more complex patients, as those patients would have more minutes spent on them? How much time are the behavioral health care managers spending on average with patients? And this could drive your service delivery for things impacting caseload capacity for your behavioral health care managers if you're more in that administrative role in governing that. It could guide referrals, conversation around hiring, more conversations around workflow. So there's a whole host of things that you could look at more intensely, looking at this kind of more broader longitudinal view. So as I mentioned previously, time tracking is also used for billing, of course. So a patient can have an episode of care that lasts over several months. On average, it could be 6 months, but of course, everything kind of depends on the patient that's in front of you. But collaborative care has billing codes that are utilized monthly for the amount of time spent providing the collaborative care service in that month. So this is considered a bundle payment for the month. The code's reimbursed amount has already included the value of the other team members' time. So when I mentioned the primary care provider or the psychiatric consultant, their time independent of the behavioral health care manager is not counted because it has already been kind of valued and put into the code around the amount of time that they would spend. So we will discuss the collaborative care billing codes over the next few slides. Collaborative care is currently covered by Medicare. There are around 30 state Medicaid programs that cover collaborative care as well. Some of them cover it at 100% of the same rate as Medicare. I can think of one state right now at the top of my head that does a little bit more than that for their Medicaid population, and others from a state level less than the Medicare rate. Most commercial insurance payers also cover collaborative care as well at 100% of the same rate as Medicare, and some commercial payers might reimburse more than that Medicare, 100% of that Medicare rate as well. So it's definitely one of those things where you need to have conversation and check into your payer reimbursement for the codes. So these are the 2023 CPT codes for behavioral health integration and collaborative care. So these codes are not available for FQHCs and RHC providers. I'll talk about that on the next slide, but they are the building blocks for the services provided. So the code on the very bottom, 99484, is a behavioral health integration code and is not specific to collaborative care. It does require 20 minutes of care management services and has specific details of what's included in care management services. And then you have your G2214 there at the top, 99492, 99493, and 99494. Those are your collaborative care codes. And just some quick considerations, because I know billing could sometimes be challenging depending on how versed you are in understanding the collaborative care codes. But G2214, the 9942, and 9943, they follow a half the time plus 1 minute rule to be billed. So for example, G2214, you'll see there it says 30 minutes for the month. So for that code, you would need to spend 16 minutes providing collaborative care services for it to be billed. G2214 can be used in the initial month, but it can also be used as a subsequent month code as well. Whereas 99492 is used for the initial month of collaborative care, and then you see that 99493 there is used for the subsequent months. And then your 99494 is actually an add-on code, so it would not stand alone as a code. So it wouldn't be used independently, but it could be added to your 99492, which is your initial, or your 99493 subsequent month code. And then to the far right, the last two columns you see show the Medicare reimbursement rate based on the facility type. So depending on what facility type you are, dictates how much you would be reimbursed for those services. And then here are the codes and their corresponding reimbursement amounts utilized for FQHCs and RHCs. There are very distinct differences with the code. Here you'll see there are only two, whereas before there were quite a few of them. So the G0511, that is equivalent to that behavioral health integration code that I mentioned on the previous slide. That was a 99484, where you provide a minimum of 20 minutes of the care management services. And then for collaborative care, you have G0512. And that code is utilized for FQHC or RHC, whether it's an initial month of services or subsequent month of services being provided of collaborative care. These codes do not follow the half the time plus 1 minute rule. For these codes, you must complete or have the full range of minutes. So for an initial month, you would need to have provided 70 minutes of collaborative care services, and for a subsequent month, you would need to have provided the full 60 minutes of collaborative care services. You'll also note that there is no add-on code here. So if you go over that, you did what you needed to do and what was best for the patients. And that's just kind of how that part goes.
So Monica, I'll just, you maybe said this, but I'll just also add in that, when you're saying that you can't use the 50% plus one rule for the FQHCs and the RHCs, back here on the BHI and collaborative care codes, the one at the very bottom, the 99484, which is for the general BHI, you can't use the 50% plus one rule for that one either. You can use 50% plus one for all of the collaborative care codes, which are the 4 codes at the top of the table, but the bottom one is you can't use that. So just wanted to add that in.
So when deciding who can benefit from the use of and be billed for collaborative care services, just remember it is any patient that has a behavioral health or substance use diagnosis. I think sometimes what we've seen is substance use diagnoses have kind of been left out, but is not the case. So any behavioral health or substance use diagnosis, patient that has a behavioral health or substance use diagnosis can be referred for and provided and billed collaborative care services. Billing with collaborative care codes means that only the minutes of the behavioral health care manager time counts. And per Medicare guidelines, the behavioral health care manager must have specialized behavioral health training. So a behavioral health care manager does not have to be licensed per Medicare guidelines and could be a nurse with specialized behavioral health training. So this qualification for behavioral health care managers can vary by payer. So it's important you look into this. Some states might have more stricter rules around who could serve as that behavioral health care manager. Collaborative care and traditional psychotherapy codes can be billed in the same month for a patient. The minutes providing these services cannot be counted twice. So for example, if you are a behavioral health care manager that is licensed and you are providing collaborative care and traditional psychotherapy for a patient, the time you spend on those services cannot overlap. So I couldn't count the time that I spent doing psychotherapy with the patient, and then take some of that time and also use it for my time in bundle payment that I'm adding up for collaborative care. So codes are billed underneath your treating billing provider or your treating medical provider as incident 2 or under general supervision. So the codes would not be billed if you are a licensed individual. You know, traditional psychotherapy codes are billed underneath that licensed clinician. In this situation, the CPT codes that are dropped are billed underneath the treating medical billing provider. So that is a difference. Codes are bundle payment, as I mentioned before, during a calendar month by team members. So you have your billing provider as that's the triangle that Diane mentioned in the beginning. So you have your billing treating provider, your behavioral health care manager, and your psychiatric consultant, as well as the patient, of course, that make up your team members. And that billing happens for all of those individuals on the team. But remember, the minutes that are being tracked and counted over time is for the activities of that behavioral health care manager, which we'll talk some about those activities on the next slide. And then prior to collaborative care services or treatment being provided, there needs to be a medical visit for the patient if they have not been seen within the last 12 months. So they would need to have a visit with that treating billing medical provider. And then patient consent for treatment needs to be in the medical chart in your EHR, and that needs to be completed by that treating billing provider, who's the billing medical provider. And part of that consent is the patient being informed that there is, for the Medicare patients, there is that Part B copayment that may apply. And so they want to make sure that patients are aware of that. And that's sometimes a little bit different for patients because they're used to being billed every time they've been seen in the office in person. And so this is a different thought process because there's a lot of work that the behavioral health care manager is doing behind the scenes that is not always going to require that immediate face-to-face or phone time with the patient that behavioral health care manager could be doing. And you can go to the next slide, Diane. That behavioral health care manager is going to be doing a lot of other work behind the scene with the psychiatric consultant, talking to different individuals that all count up that time that the patient is not having that kind of direct face-to-face with. So that's a different concept for patients to understand that that time is being built up behind the scenes and going to be billed for. So some of the activities that are required for billing collaborative care codes is that there is engagement and assessment utilizing a validated screening measure that results in a treatment plan. So for some individuals, that's the PHQ-9, GAD-7, things of that nature. It also is required that there is a weekly systematic caseload review, and this is the thing that happens with the psychiatric consultant. So it's the psychiatric consultant and the behavioral health care manager that typically attend the systematic caseload review, discussing the patient, making modifications to the treatment plan and recommendations, and sending those to the treating billing medical provider. So it is not the case that the medical provider has to attend the systematic caseload review. That was a misconception in the past, but they do not have to be there. By all means, if they have the time and they'd like to, of course they can, but we also want to make sure that we're making good use of their time. So if they are not there, that is completely fine. It is not intended for them to be. Those systematic caseload reviews are intended for the psychiatric consultant and the behavioral health care manager. Also required is the use of a registry to track visits and outcomes. And so you saw some examples, and we'll be showing some in a couple more slides of our AIMS caseload tracker, which is the registry that some sites use. Other sites have registries built into their EHR and things of that nature. And that there's ongoing collaboration with the PCP, the primary care provider, and other treating providers for the patient. So that's some more of that behind the scene conversation that the behavioral health care manager might be having with other members of the patient's care team. And then there is the ability to provide brief evidence-based behavioral interventions. There are occasions where patients don't want any of the behavioral interventions. And I think in the past, individuals have assumed that if a patient only wanted the medication, kind of the medication management recommendations, that that's the only way that a patient could be, that a patient had to have both that and brief, evidence-based brief behavioral interventions. That's not the case. Some patients choose not to have the brief behavioral interventions, and they could still be a part of collaborative care. And then, of course, there's ongoing monitoring, utilizing the validated scales. And then there's relapse prevention planning for once a patient is starting to do well and their episode of care, you could see that might be coming to an end because you'll be monitoring your caseload utilizing the time tracking and registry. You might decide that it's almost time to start discussing relapse prevention planning with the patient. So those activities as well are considered a part of collaborative care. So in terms of billing workflow, it's similar if you are an individual who has utilized chronic care management coding. You can use some similar billing workflows to that. Collaborative care is billed typically at the end of a calendar month. Once the services for that month are completed, it's billed again underneath the treating billing medical provider. So it's incident to billing. And it's the monthly summary of activities that you've provided to that patient that should be included in the documentation with the bill. So one thing that most individuals will do is for their workflow, they'll open an encounter with the first activity of the month for the patient, the first collaborative care activity for the month, and they'll keep that encounter open and add activities and time over the course of the month that's being provided to the patient. And then at the end of the month, the behavioral health care manager typically will be the one to close out that episode of care and close out the encounter that was open for the month and drop the bill. So you're not billing for each time the behavioral health care manager is doing an activity. You're just billing at the end of a calendar month for those activities. So the patient would get that one copay when that bill is dropped at the end of the month. Of note, of course, is about the add-on code, that it must be, as I mentioned earlier, billed with an originating code. So with the 99492 or with the 99493, it could not stand alone. So this is just an example of a workflow, and I say example because there are different ways that people decide to keep encounters open and track and things of that nature. So care services. So the PCP documents the consent and puts in the referral for collaborative care. And that consent specifies the cost sharing piece that we discussed. Then it goes to the right, in the middle there, top blue box, which is number 2, you initiate a collaborative care episode of care. So the behavioral health care manager would verify that there's consent, hopefully in the EHR, and then they would create a collaborative care episode per the patient at the beginning of the treatment episode for that month. It says or monthly because we have seen different ways that people have done this, depending on your EHR and how episodes of care are created. Then you would go to the right, top right green box. Number 3 is monthly encounters. So throughout the month, you create a non-billable collaborative care encounter and document the time spent for each encounter. And you would link the encounter to a collaborative care episode of care. So this again is based on how you decide in your EHR what capabilities you have in your EHR. So what happens is in some EHRs, you can open an episode of care and then each encounter just attach it to that episode of care, and that episode of care could stay open as long as you're treating the patient. And then in some EHRs, an episode of care is used for the month. It doesn't mean that the patient's treating episode of care is ended. It just means that all of the collaborative care episodes that are happening that month are ended, and then they close out that encounter and send it that way. So those are kind of the two ways that we've mostly seen it done, and it again depends on the EHR you're using. And then you come down to box number 4, where you have the sum of the monthly minutes that are used at the end of the calendar month. Those are totaled up for the month. Then you go to step 5, which is in that middle box, the last monthly encounter. You would add hopefully a smart phrase, so, because you'll typically be using the same wording in that encounter of the services you provided for that month to the patient, the total minutes involved. You'll link it if you need to link it. And then you move on to step 6, which is the far left blue box, charge capture, where you might need to add the treating medical provider's name to it, as they are the billing provider, and the behavioral health care manager is the rendering or service provider. You select whichever diagnoses that has been determined with the collaborative care team, and then you would drop the CPT code for collaborative care that corresponds to the total minutes that you've tracked for the month. And then you go down to submit. You review your documentation and minutes, submit that for charges. If you have a department that does that, because that also we see differently depending on organization. Sometimes it goes to a department that reviews everything and then officially drops the code. So that part also could vary depending on your EHR.
Thanks, Monica. I'm going to talk a little bit about time tracking as it relates to activities other than billing. There are some good uses of time tracking for purposes other than billing. So let's talk about those here for just a minute. This view of the AIMS Caseload Tracker Registry shows all of the active patients for one behavioral health care manager. And by looking at the patient who's highlighted here, you can see that the minutes spent in the current month is one indicator that it might be time for a relapse prevention plan and then ending the episode of care. So you can see that there have been no minutes in that month. And then if you go into the column, it's the 4th and 5th columns from the left. You can see PHQ-9 first and last and GAD-7 first and last scores. The last score for the PHQ-9 indicates that there, was an increase in symptoms. So maybe not relapse prevention planning, but maybe trying to get that patient back in to care. So you would use the minutes to help you kind of look at someone and then be able to make some determinations about what the next step might be. So this is a screenshot of the monthly time tracker that Monica showed earlier. So in this view, each row is a patient, and then you can see over the course of an entire year what the minutes were for each of those patients. And, if you look at this, you can see that there are, a number of patients there in the highlighted area that have had 0 minutes for a significant number of months. So, if you see something like that, then it's worth it to consider whether those patients should be discharged from the active caseload to make room on the caseload for new patients. So you can also use the total number of minutes on the bottom of this report to assess the capacity of your collaborative care program. So at the very bottom, it says all, the bottom row, and you can see the total number of minutes for each of the month by behavioral health care manager. So are you billing enough minutes for the program to be financially sustainable? So you could consider what is happening in the months when the total number of minutes is particularly low. Was there a clinician who was out on leave, or was there turnover in the behavioral health care manager role? What is the total number of minutes that's reasonable and sustainable from both a workload and a financing perspective? A program manager could use the data in this report to monitor whether you're significantly above or below that kind of optimal number. And then similarly, you can use a report like this to help you assess patient acuity, and that's something that Monica talked about earlier as well. So perhaps that's a factor that helps explain significant variations in the total number of minutes from month to month as you're looking at that bottom row. So there are several methods for capturing the minutes spent, especially when those are minutes that are outside of a scheduled appointment. So you can use your phone or an app to help you keep track of minutes over the course of the day, especially when you're away from the registry or the EHR. You can also jot the time down on a piece of paper if you're an old school person. You want to record the minutes as close to when you use them as possible so that they're accurate. So at the very least, you want to count the minutes no later than the end of the day. So there are several ways you can aggregate the minutes for billing and program monitoring purposes. You can do that in your registry, in your EHR, or even in an Excel spreadsheet. So the AIM Center has many resources regarding billing and financing collaborative care on our website, and the website address is up there at the top. We invite you to check those out, including a recorded webinar with a panel of speakers who talked about how they handle billing and financing. And then we also host a national office hours each month that's focused on billing and financing for collaborative care. It's open to anyone who wants to participate, and I encourage you to check that out as well. And now let's open it up for discussion and questions.
While we're waiting on discussion, I'll also put in a plug that we have office hours for implementation. So I know individuals sometimes have questions and challenges about implementing collaborative care in general, and we have separate office hours for implementation than for our billing and finance.
Thank you, Monica.
I will say there was a question posed earlier on about whether or not collaborative care is a different integrated care model than PCBH, was asked earlier, Diane. So I don't know if you wanna.
Yeah, I saw that in the chat, and thanks for handling that in the chat, Monica. So, there are various ways of doing behavioral health integration, which is really just integrating behavioral health services into medical settings, including primary care, but can also be specialty settings like a cancer center, a diabetes, care clinic, women's health, et cetera. Collaborative care is one of those methods. It is the only method that has its own specific Medicare billing codes that are specific to collaborative care. And you do have to have all those elements of collaborative care that we were talking about earlier in order to build those codes. It is the model of integrated care that has the deepest evidence base behind it. There's at this point, about 25 years worth of research behind collaborative care that shows that it gets twice as many people better in about half the time, or more than half the time. And so it's significantly clinically, advantageous. And then there have also been cost effectiveness studies that have been done showing that collaborative care also saves money in terms of utilization of costs, utilization of healthcare, that is, in all cost categories, including inpatient and outpatient medical services, inpatient and outpatient mental health services, and pharmacy. So it's got a really strong evidence base for its clinical efficacy, as well as for the sort of long-term cost effectiveness. Yeah. And maybe Monica, and the PCBH approach is typically, there really are kind of two patient populations that are a little bit different in terms of the patient population you're focusing on. Collaborative care is designed for patients who have a diagnosable mental health condition. So they've got a diagnosed, depression, anxiety, post-traumatic stress disorder. There's even recent evidence around bipolar disorder. And these are folks who've got a diagnosed mental health condition for which you're providing treatment. My understanding of the PCBH model, at least as it was originally conceptualized, is that it's more focused on folks who have an intersection of their medical condition and a behavioral health component that's affecting their medical condition. And so you're doing kind of brief interventions with them to help them get on track and to address that behavioral health condition that's affecting a medical condition. I don't know if there's anything you want to add to that, Monica.
No, I think you worded it perfectly. So I have utilized both models in practice, and yes, PCBH is very much, you could take anyone that comes through the door. It's not a targeted approach per se, and it is about functionality, helping that patient to increase their functionality because something that's going on in their life is impacting or could impact their medical condition. So a lot of comorbid conditions and things like that come through. So you described it very well.
Any other questions about time tracking?
So while we wait for others to think of questions, I did have 2 emailed to me. So I'm just gonna, and I know you've addressed some of them already, but just to reiterate, the first question was that, is documentation in the EMR counted towards the time?
So if you're doing clinical documentation into the EMR or into the registry, you can count that time, but it should be minimal. So, that's our recommendation, is that you're thoughtful about how much time you're counting on charting. So you should be able to get to the point where, you're not spending 20 minutes on charting. So you can count that as a clinical activity, but be careful on how much time you ascribe to that.
Right.
Yeah,
And
I'll add to that, Sujina, if that's okay. That, as a, being out in the field, and especially when you first start and you're trying to figure everything out, documentation and doing clinical charting can take some time. Again, and we have different individuals that document differently. Some will document concurrently, which just means they're documenting as they're providing the service or talking with the patient and all of those things. And then there are others who maybe that just doesn't work for them, and so they write everything down on a piece of paper and then go document. So we just want to make sure, I think the reason why minimal is there, that we don't have such a variance between the person whose personal style just takes longer. So when I was the behavioral health director at a practice, we kind of just had a standard that it was 2 minutes. Was that all you could add for a patient? And so sometimes that's a discussion from a program level that you do need to have, so individuals are aware and just not taking their own personalized documentation style that might take longer into consideration.
thank you, Monica. Before I go on to the second question, does anyone else have any questions to ask? Okay, then I'll ask my second question. The second question was that outreach is only listed for 99492. Does that mean it does not count for 99493 or activity in following months?
Yeah, if you're doing outreach, that's not just in that initial month. But again, I think when we have to get to, is it a clinical outreach? So you'd want to differentiate between, did you make an outreach phone call that didn't connect with the patient and maybe you just left a message? That would not, in our opinion, that would not qualify as a clinical activity. But if you make an outreach attempt and you connect with the patient and you have some kind of a conversation with them that goes beyond just scheduling an appointment, and includes anything about, how they're feeling and what their symptoms are like, and if they, are following up on their behavioral activation goal or anything clinical, then you can go ahead and include that in the subsequent months as well. So you can include that with the 99493 or the G2214, or even if you're if that's part of your 99494. So it isn't limited to the initial month, but you do need to differentiate between whether there was any clinical content to that outreach attempt.
Got it. Thank you. Any other questions for Diane or Monica? Please feel free to unmute yourself or type your questions in the chat if you're not comfortable speaking up.
Maybe it just means you have some excellent time trackers on this call, huh?
No doubt. Let's see.
Anybody find it challenging, I'm wondering, just in terms of figuring out consistency with time tracking and how your behavioral health care managers time track? All right.
Okay, I think we're good to go. I don't think there are many questions. But thank you, Monica and Diane, for your time today and for doing such an amazing session. We really appreciate you coming in and giving this time for us. Thank you, everyone else, for joining.